Hello, my name is Ivanna Montalvan, and my topic is Belatacept and long-term outcomes in kidney transplantation. Okay, as a definition, we have that Belatacept is a selective co-stimulation blocker that has been developed to improve long-term results in kidney transplant recipes by providing effective immunosuppression without the toxic effect of calcineurin inhibitors. Now we're going to see a video.
Of the study. Among 666 patients after kidney transplantation. Advancement in post-transplantation immunosuppressive management has reduced rates of acute rejection and improved one-year outcome in patients who underwent kidney transplantation. But there is no improvement in long-term renal allograft survival due to cardiovascular disease and chronic allograft neuropathy. Belatacept is a selective co-stimulation blocker designed to provide effective immunosuppression and avoid renal and non-renal toxicities associated with calcineurin inhibitors. The main objective of the study is to determine long-term outcomes of belatacept in patients who had kidney transplantation, to assess the patient and graft survival, renal function, and incidence of acute rejection in each belatacept group compared to cyclosporine group. The study design was a 3-year international, randomized, single-blind parallel group study with an active control. Kaplan-Meier method and cyclooxygenase regression methods were used to determine statistical analysis of the study. Among 666 patients who underwent randomization, 153 patients were evaluated for more intensity belatacept, 163 evaluated for less intensity belatacept, and 131 evaluated for cyclosporine after 84 months. The inclusion criteria for the study was 18-year and older patients who received a living donor or standard criteria, deceased donor kidney transplant. The exclusion criteria for the study was donors of more than 60 years age or more than 50 years who had at least 2 risk factors like cerebrovascular accident, hypertension, anticipated cold ischemia of more than 24 hours, patients who received a kidney after cardiac death of the donor. Patients with concurrent, non-renal solid organ transplant were also excluded from the study. Patients assigned to take belatacept, more intensive were provided 10 mg per kg drug on days 1 and 5, and at weeks 2, 4, 6, 8, 10, and 12. For 4 to 6 months, 10 mg per kg at weeks 16, 20, and 24. Beyond 6 months, 5 mg per kg drug for every 4 weeks was given. For the patients assigned to take cyclosporine, initial daily dose was 4 to 10 mg per kg, which was adjusted to 150 to 300 nanograms per milliliter up to 1 month, and 100 to 250 nanograms per milliliter beyond first month. The participants were randomized into 3 groups and underwent kidney transplantation. Different groups of patients were treated with the drugs belatacept and cyclosporine in different doses. Different parameters were evaluated in 12, 36, 60, and 84 months. The parameters evaluated in the study were efficacy, that includes rate of death and rate of graft loss, estimated glomerular filtration rate, safety of the drug, and rate of development of donor-specific antibodies. Estimated glomerular filtration rate was calculated with the use of 6-variable modification of diet in renal disease equation. The graph was plotted on the basis of Kaplan-Meier to estimate the rate of death with more intensive belatacept, less intensive belatacept, and cyclosporine for 36, 60, and 84 months. It was proved that the rate of death with belatacept regimen, more intensity and less intensity, was less when compared to cyclosporine. The graph was plotted between the hazard ratio for belatacept more intensive with cyclosporine and belatacept less intensive with cyclosporine for 60 and 84 months. The graph was plotted to estimate the rate of graft loss among the patients receiving more intensive belatacept, less intensive belatacept, and cyclosporine, with censoring of the data for death for 36, 60, and 84 months. The rate of graft loss with belatacept treatment regimen was less compared to cyclosporine. The graph was plotted for the comparison of the hazard ratio of more intensive belatacept and low intensive belatacept with cyclosporine for 60 and 84 months. At month 84, the cumulative frequencies of serious adverse events in patients receiving more intensive and less intensive belatacept regimens and for cyclosporine were 70.8%, 68.6%, and 76.0%, respectively. The graph was plotted to estimate the glomerular filtration rate for 12, 36, 60, and 84 months. The mean estimated glomerular filtration rate was calculated per minute per 1.73 meters square for each group of patients. It showed the significant difference in the estimated glomerular filtration rate favored each belatacept regimen over cyclosporine. The Kaplan-Meier cumulative rates for the development of donor-specific antibodies at months 36, 60, and 84 were plotted. Development of donor-specific antibodies was significantly lower with each belatacept regimen than with cyclosporine. From the above results, it is proved that 84 months, that is, 7 years after kidney transplantation, patient and graft survival, and the mean estimated glomerular filtration rate were significantly higher with belatacept, more intensive regimen, and the less intensive regimen than with cyclosporine.
Okay, continue to with the presentation. We are going to talk about applications in medicine. Okay, current standard immunosuppressed regimen combine calcium inhibitors with anti-proliferative drugs with or without maintenance glucocorticoids. However, calcium inhibitors based regimens may not adequate preserve allograft functions, leading to deteriorations of kidney function, which is the risk factor for cardiovascular death in kidney transplant recipients. The lack of improvement in long-term patients that and graft survival is multifactorial but cardiovascular disease, nephrotics associated with calcium inhibitors and lack adherence to treatment. Okay, which are the pros and cons? As a pro, we have that belatacept is approved for use only in patients who are positive for Epstein-Barr virus, given the increased risk of post-transplant lymphoproliferative disorder, which predominantly affects the central nervous system. Patients randomized to a more or less intensive Belatacept regimen had the 43% reductions in the risk of death or graft loss at 7 years. As a cause, we have that the most notable consequence that we can observe in Belatacept is that although it has better long-term effect and prevents the appearance of adverse effects in less quality and better than other medication. It is not on the 100% certain that these adverse effects will not appear with time. Okay, applied in Ecuador. Okay, we have a total of 660 participants with randomized assigned to a study group and 100 under transplantation. Of the total who were treated, we have that 153 of the 290 patients treated with the more intensive Belatacept regimen, and we have that 163 of 226 treated with the cyclosporine regimen, and these have to were followed for the full eight, 84 month period. Okay, conclusion. We can release the effectiveness of elatoxin. It have great long-term action that other medications and helps avoid the adverse effect that may occur over the time after a transplantation. Thank you.